Yeah, thank you. So preservation, my topic of presentation is preservation of axillary lymph nodes compared to complete dissection in T1, T2 breast cancer patients presenting with 1 to 2 metastatic sentinel lymph nodes, a multi-center randomized clinical trial, the SINODA 1, with the chief PI being Damino Gentile. So at the background, axillary lymph node dissection has always been a part of the breast cancer treatment. However, the management of axilla has shifted towards a more conservative sentinel lymph node biopsy has now replaced axillary lymph node dissection in node-negative breast cancer axillary staging. The complete axillary dissection may now be considered over treatment for early breast cancer stages, and the recommendation is being challenged because some of the following considerations that now the diagnosis tends to be earlier by screening mammography. Less than 50% of the patients with sentinel lymph node metastasis usually present with additional metastasis, and the majority of the sentinel lymph node positive patients not undergoing axillary nodal dissection will either receive chemotherapy or endocrine treatment as a part of the management. So axillary lymph node dissection remained the standard surgical technique when the sentinel lymph node is macrometastatic. So the American College of Surgeons Oncology Group, the Z0011 trial, they questioned the therapeutic benefit of axillary lymph node dissection in patients who had metastatic sentinel lymph node. Patients undergoing breast cancer surgery, conservative surgery, and whole breast radiotherapy with 1 to 2 metastatic sentinel lymph nodes were randomized either to axillary nodal dissection or no further axillary treatment. But the trial concluded that axillary dissection did not provide any outcome advantages. But this trial had some controversial issues and limitations due to there was the premature enrollment of conclusions. There were too many patients, more than 20% were lost to follow-up. Half the patients presented with micrometastasis, and there was lack of radiation quality assurance with missing data for more than 2/3 of the randomized patients. So the rationale for this SINODA 1 trial, the majority of the limitations of the Z0011 trial seriously confounded the interpretation of the final results, being impossible to extrapolate and generalize the findings beyond the low-risk study population. So the breast unit of the Humanitas Clinical Research Center, the Milan, Italy, they promoted the multicentric clinical trial, the SINODA 1. So what does the SINODA trial 1 is? It's a prospective non-inferiority multicentric randomized study which aims at assessing the therapeutic role of axillary lymph node dissection in patients who are undergoing either breast conservative surgery or mastectomy for T1, T2 breast cancer presenting with 1 to 2 macrometastatic sentinel lymph nodes. So 52 different Italian centers have been participating. The enrollment has completed in April 2020 with the follow-up is ongoing. So the study design, the inclusion criteria was they have taken age more than 40, less than 75, invasive breast carcinoma, ET2, and clinically node negative axillary. There should be no more than 2 sentinel lymph nodes with a proven metastasis, and the macrometastasis should be more than 2 millimeters. There should be no distant metastasis, no neoadjuvant chemotherapy or a neoadjuvant hormonal therapy. There should be no previous history of invasive carcinoma. Patient should have given a written informed consent. Whereas the exclusion being the pregnancy, breastfeeding, inflammatory breast cancer, in situ breast cancer, synchronous contralateral breast cancer, the comorbidities which prevent giving adjuvant therapy to the patients, disease or comorbidities which might be preventing her compliance to a regular follow-up, or there was a previous history of neoplasm, except the carcinoma in situ. So the randomization was done in a standard arm, which included the axillary lymph node dissection plus adjuvant therapy, whereas the experimental arm, there was no axillary treatment, but adjuvant therapy alone. So the primary endpoints are the overall survival, whereas the secondary being the loco-regional recurrence-free survival and distant disease-free survival. So the results have been interpreted, which have been that they have included randomized till now 889 patients. There were 443 in the standard and 446, but 4 were excluded in the standard arm. So finally, there were 439, the intention to treat population, whereas 440 in the experimental, 6 being excluded. More than 75% of the patients in both the arms included the breast conservative surgery, whereas the mastectomy included 22 and 23%. The mean sentinel lymph node excised were 1.96 with a median of 2 in both the arms. There were 341 patients with 1 sentinel node in the standard arm and 2 in 96 patients, whereas 326 patients and 110 with 1 and 2 respectively in the experimental arm. The micrometastasis was present in 2 patients in standard and 3 in the experimental. The 417 patients had undergone axillary dissection in the standard arm, whereas there was a deviation in the protocol in the 22 patients, and also the positive non-sentinel lymph nodes have been excised. There were 193 cases with a mean of 1.4 nodes, and the median positive sentinel nodes being 0 to 22, whereas none of the 13 patients had undergone a deviation and had undergone axillary dissection in the experimental arm. So the follow-up events, there were 16 events in the standard and 20 in the experimental arm. There were 4 mortality in both the cases, both the arms, with 1 axillary recurrence in both the arms. There were 0 ipsilateral breast recurrence in the standard and 3 in the experimental arm. 7 distant recurrence and 8 in the experimental arm. Second primary tumors were 5 in standard and 6 in experimental arm. Follow-up, the median has been 33.3 in the standard and 34.5 in the experimental arm. But none of the results have been statistically significant difference in terms of survival and recurrence in the 2 different groups of treatment. So they have compared the timing of axillary recurrence, and they have found that when compared to the previous studies, the median follow-up of the Sanodarm 1 arm as concerned to the median axillary relapse-free time has already crossed, and they have a follow-up of more than 34 months. So there have been 4 major trials, which non-inferiority trials, which are comparing the axillary dissection with versus no axillary treatment in early breast cancer, which might answer these questions: Z011, Synodar 1, the POSNOC, and the INSAMNA. The main differences between the 4 trials are between the age recruitment, with the Synodar 1 more than 40, less than 75, whereas the Z011 and the POSNOC have included more than 18 and INSAMNA more than 35. Secondly, they are varying in the surgery type. The Z011 and the INSAMNA have included only the breast conservative surgery arms, whereas the Synodar 1 and the POSNOC both are including the breast conservative surgery and mastectomy patients. So to conclude, though, there has been an overlap between the results of Synodar 1 trial and those of the Z011, and these are very convincing. The breast unit of the Humanitas Clinical and Research Study believes that the condition of uncertainty that justified the randomization between complete axillary dissection and omission now no longer exists. And they also expressed a favorable opinion on the proposal to include omission of complete axillary dissection in the internal guidelines. Now, the takeaway and the Indian perspective on this trial, the Synodar 1 is expected to provide more robust evidence on the safety of LND omission in well-defined and possibly larger population of patients with limited sentinel lymph node macrometastatic disease. So, our perspective in an Indian scenario, the Synodar trial has included an age group of more than 40 and less than 75. But the proposal should be that we should also include the patients who are more than 18 years of age group, because they have some aggressive histology. So 18 and 39 should also be addressed. They have included more than 75% of the breast cancer conservative surgery, but a major chunk of the population should also include the mastectomy, where we can avoid the post-mastectomy radiation as well. Adjuvant therapy, Synodar 1 had included whole breast irradiation with BCS only, whereas in Indian perspective, as we get more of mastectomy patients, we should include whole breast irradiation for BCS and PMRT only if indicated, and there should be a subgroup analysis how they fare in the long follow-up. Quality assurance has not been mentioned in the Synodar 1 trial, but in Indian perspective, yes, we should include that part also. Secondary endpoint, they have included the loco-regional recurrence-free survival and the distant disease-free survival. The quality of life parameter is a very important parameter which needs to be assessed, and we propose this for an Indian perspective. And also a subgroup analysis of factors such as age, grade, receptor status, and LVCI, which may be associated with a higher risk of axillary recurrence. Thank you.